Hello, my name is Jeff Kordower, and I'm the founding director of the NRDC at Arizona State University. It's my pleasure to be invited by the World Parkinson's Congress today to talk about a very important topic, the neurobiology of cognitive decline in Parkinson's disease. I just want to show you, first of all, my conflicts and also acknowledge the fact that some of the slides in this presentation have been obtained online from Dr. Matt Barrett's presentation and others on loan from Dr. Jennifer Goldman. So what is the status of cognition in Parkinson's disease? Well, first of all, very early form of cognitive decline called mild cognitive impairment is present in 15 to 20% of patients at diagnosis, and the cognitive decline is insidious. Typical profile of a patient with cognitive decline is impaired attention, deficits in memory, the recall of memory, not the learning or encoding of the memory, impaired physiospatial function, impaired executive function, and there's quite a bit of heterogeneity in the cognitive profile, but 15 to 20% of PD patients at first diagnosis already have cognitive impairment. Parkinson's disease dementia, or PDD, is in 3 to 4% of all dementia patients. 10% of PD patients develop dementia annually, and there's an 80% lifetime prevalence, of the development of cognitive decline and dementia, and we really have very little therapeutic strategies for which to address these issues. Dementia, like falls, is one of the 2 features that get subjects and patients into nursing homes, and so this is an incredibly powerful unmet need in terms of therapeutic intervention and understanding of the neurobiology of Parkinson's disease dementia in the first place. So how does one diagnose Parkinson's disease dementia? Well, first of all, there are some core features. And first of all, the diagnosis is made using a UK brain bank criteria. And then these patients have a dementia syndrome with insidious onset, slow progression, and develop in the context of established Parkinson's disease. And the diagnosis of Parkinson's disease is made by impairment in one or more cognitive domains, representing a decline from premorbid levels, and deficits severe enough to impair daily life, social, occupational, or personal care, independent impairment attributable to motor or autonomic symptoms. So these are events that are distinguished from the motor and autonomic features that are seen in patients with Parkinson's disease. Certain areas are particularly involved. Language can be involved, although less impaired in language deficits one sees in Alzheimer's disease. Visual spatial impairments, significant impairment more than AD. Executive function, impaired typically more than AD. Attention, impaired and may fluctuate. And memory, visual and verbal memory impaired, but less than what's seen in Alzheimer's disease. Retrieving data, more impaired than encoding data, is what I just said in the previous slide. What's also common in terms of the cognitive decline are other comorbid symptoms, and many of them are psychiatric. You can get psychotic symptoms, where 45 to 65% of patients get hallucinating. There are 20 to 35% of patients have delusions. These hallucinations tend to be more visual than auditory, more common in PDD and DLB than Alzheimer's disease, and paranoid phantom boredom misidentification. These are all features that are comorbid with cognitive decline in Parkinson's disease. So how does one make a diagnosis of dementia with Lewy bodies versus PDD? Use the 1-year rule, and this is based upon the 3rd report of the dorsal dementia with Lewy bodies consortium. DLB should be diagnosed when dementia occurs before or concurrently with Parkinsonism. And PDD should be used to describe dementia that occurs in the context of well-established PD. And so if you have a long-standing motor Parkinson's disease and you start to develop dementia, then that is PDD. But if it comes on at the same time, then we use DLB as the diagnosis. And the 1-year rule between onset of dementia and Parkinsonism for DLB should be used in a scientific setting. So what is the pathology of Parkinson's disease dementia? Lewy pathology in the cortex and limbic structures are a cardinal feature of this disease. And what you can see here in the upper right is a cell with a alpha-synuclein stained Lewy body. And look at the core of this. This is in the cortex. And I know that because it is a solid Lewy body. And I'll show you some other non-solid Lewy bodies in different parts of the brain. But in the cortex, this is what a Lewy body looks like. Hallucinations are an indicator of Lewy body pathology. But there is Alzheimer's pathology that is frequently present. In fact, it is rare that there's a postmortem of a Parkinson's patient where it's solely a synucleinopathy. And there's also cerebral vascular pathology. Mini strokes are one of the factors that drive progression in Parkinson's disease. So this is now the famous drawing of Heiko Brock and Heiko's hypothesis that Parkinson's disease starts in the gastrointestinal system or the nose or olfactory bulb. In the olfactory bulb, it spreads up into cerebral cortex, but mainly he believes that the pathology spreads from lower brainstem and moves rostrally through the medulla to the midbrain, then finally up to the cerebral cortex. And in addition, this graph down here demonstrates that not only is there Lewy body pathology in many of these cases, but we also have neuritic plaques that are the hallmarks of Alzheimer's disease. And there's also neurofibrillary tangles that can be seen with phospho-tau stains. So Alzheimer's pathology and Parkinson's pathology very often coexist in the same individual. And these are examples of more Lewy bodies. You can see here, this is with hematoxylin and eosin staining, that there's this inclusion that in the center is hollow, but the inclusion is more rounded. And that's what you see in the substantia nigra of patients with Parkinson's disease, in contrast to what you see, what I just showed you in the cerebral cortex. And then you can see here that when staining for alpha-synuclein, this is how Lewy bodies develop. First of all, this is a neuromelanin positive cell. You start to see the accumulation of alpha-synuclein. That alpha-synuclein tends to aggregate more around the periphery and less in the center. And this is what the classic feature of a Lewy body is in the substantia nigra. Quite different than what's seen in the cerebral cortex. And also, if you pull out the genes of these cells, you find that the genetic overlap between a nigral Lewy body and a cortical Lewy body is quite distinct. So there are other measures for pathology in patients with Parkinson's disease and cognitive impairment. So you can see here with these dots, and this is two different types of analysis. This is, the red is voxel-based morphometry, the green is a surface-based analysis. And you can see that, just looking at the red for now, that there is a progression of pathology or atrophy of the cerebral cortex using voxel-based morphometry, going from Parkinson's disease with MCI to Parkinson's disease dementia. There is also significant white matter changes. We really don't talk much about the white matter changes that are seen in Parkinson's disease, but they are there, and they exacerbate going from PD-MCI to PDD. You can see all the regions in these two different clinical entities that are changed. Also, there are changes in functional connectivity in the posterior areas using fMRI, and decreases in connectivity in the inferior occipital and parahippocampal gyri as you go from MCI to Parkinson's disease dementia. There are also changes that are seen in biomarkers, such as in MCI, you see a decrease in amyloid and a bigger decrease in amyloid with PDD. And you can see these other changes that are frequently seen, although it's less consistent. And there are also these changes that are seen on FDG PET, again, mostly in the cerebral cortex, but also in some cortical structures as well. So what about the levels of transmitter function or dysfunction? People are very interested in dopamine all the time. And these dopamine's effects on cognition are complex, and it's a U-shaped function. And what you can see here is that if you are in the right dopamine level, Dopamine, such as levodopa, can actually improve performance, but under most circumstances, performance is decreased when you're at the either low levels of dopamine or high levels of dopamine. There are other areas that of neurochemical signatures that are significantly impacted in Parkinson's disease. Looking at the locus coeruleus, which provides norepinephrine to the cerebral cortex, the nucleus basalis, and the thalamus, and the hippocampus. And I'll show you the data that this is markedly impaired. Less consistent are changes in serotonin, but serotonin innervates the cerebral cortex, also the striatum, and also the hippocampus. And there are changes in serotonin in many studies seen in Parkinson's disease. We'll go into a little bit more detail with acetylcholine. So if you look at the basal forebrain, which is the area of, that provides acetylcholine to the hippocampus and to the all the cortical mantle, you can see that if you look at Parkinson's disease with fluctuating cognition and Parkinson's disease dementia, not in the part that innervates the hippocampus, but the part that innervates the cortex is significantly decreased. And if you look at the numbers of cells that are with normal and low levels of cognition, there's a decrease in the number of percentage of people with normal levels of nucleus basalis neurons. And this is clearly enhanced in patients with over time, especially those that are in the Parkinson's disease dementia domain. And then if you look at subjects with high nucleus basalis neurons over time, and you can see those with low nucleus basalis neurons in time, those with the green, you can see those patients, the global cognition worsens significantly over time, as does semantic fluency and phonemic fluency. So nucleus basalis seems to be involved in Parkinson's disease cognitive decline. And Elliot Mufson and I demonstrated a number of years ago that if you look at on the right-hand side, a patient with Parkinson's disease dementia, and a patient who's normal on the left using a marker for these neurons, you can see dramatic diminution from the number of these cells going forward. And these in cortex, there's a dramatic reduction in the number of fibers that contain acetylcholine. There is significant impairment in cognition of norepinephrine. So you can see here all these norepinephrine innervates the cerebral cortex. There are all these measures of impaired cognitive function based upon these areas. And you can see there's a lot of Lewy pathology and cell loss in Parkinson's patients, even at very early stages. So in conclusion, cognitive decline occurs in the vast majority of PD patients, often leading to dementia. It remains the major unmet need of this disease. The mechanisms of cognitive decline is multifactorial, with cortical pathologies and multiple neurotransmitters involved, and far more research is required for this domain. I thank you very much for your attention.